Into another district anaesthesia talk. Today we're going to be focusing on the confidential inquiries process that occurs in South Africa and some of the lessons we can learn from it, particularly for the district hospital anaesthetist. Now, the Saving Mothers report is a report that's been that's produced every triennium, every 3 years, and there have been 8 comprehensive reports since the inception of this process. That started on the 1st of October 1997 when we started recording and analyzing maternal deaths. And we're the only African country that does this routinely. There have been isolated reports from other countries, but we do this every triennium. And these reports and the data that they represent are responsible for key recommendations, national guidelines, and they are the members of the National Committee are appointed by the Minister of Health. So it's a process the government takes very seriously. Now, this process, it's key that you understand how it works so that you know where all these data are collected from and what happens to the forms that you fill in. Remember that all maternal deaths require the forms called MDNF forms, maternal death notification forms, and a meeting that happens at a local level. Not all post-maternal deaths need a post-mortem, but all perioperative deaths do because they've had a procedure. So those are peri-procedural, what we used to call anesthetic deaths, and therefore they're non-natural and require a post-mortem. Natural deaths don't require a post-mortem, but often medical managers like to have them done because of the medico-legal implications around these things, but you can't actually by the law insist on one like you have to with a peri-procedural mortality. This is the process that occurs following a maternal death, and it looks quite complex, but really it's only this area here that applies to the district hospital. So following a maternal death, you have to notify the death, and then you fill in the MDNF forms. That meeting must happen within 72 hours with all the senior stakeholders present. You fill in those forms, which are then sent to the provincial coordinator, and then those forms plus the clinical record are then reassessed by the provincial NCC-EMD committee, who then generate their own assessment, and those sets of data are then put into a national confidential database. Importantly, those forms are confidential and they're extremely helpful, so they must be filled in honestly and appropriately. Tell us everything that happened, what you think was avoidable, and you can put it all in there. It's very important that you don't make copies and keep those in the patient file or in your own desk, because if those copies do make it into the medical legal system, they become less confidential when they're in the hands of an opposing lawyer. So really it's a time to be careful about these sort of things. At the provincial committee, which I sit on, we certainly don't look at doctors' names and come after them. That's never ever done. But if there were mistakes made, they do sometimes inform guidelines that come out of that committee. It's very important that the process stays confidential, otherwise nobody will tell the truth in these forms for fear of litigation. The second thing that should happen at your local facility is mortality and morbidity meetings, and all maternal deaths should be discussed at these meetings just to make sure there's no avoidable things, for self-reflection, looking for things that the facility can do better. And remember, that should be a safe space. So it's not a place where we're looking to blame. It's a place where we're looking for things we can do better. And finally, remember the other local responses. Use these events to change and grow your hospital to get better. And remember to debrief. I think healthcare workers take a lot of stress around these events. It's a tragedy for the family. What's supposed to be this joyous event turns into tragedy. And it's hard on us as healthcare workers. It's obviously hard on the family. And remember that we need to check that we're okay. So is your institution mindful, cognizant of that fact? Now, this is the overall picture for maternal deaths from 1998 to 2022. And you can see that maternal deaths initially were climbing until about 2009. Then they started dropping off. And that climbing might have been due to better reporting, or it may have been a real signal. Here's the institutional maternal mortality rate, which shows that little blip around 2021 and 2022 better. So that's it there. And that is secondary to the COVID pandemic, where we saw a lot of maternal deaths in that period, and you see that spike. But the overall trend since about 2009, 2010 has been downwards, with the exception of that those 2 years during the pandemic. And that's good. So how have anesthetics been doing? Well, in terms of the percentage of maternal deaths that are due to anesthesia, it's fairly static. And a static proportion of deaths would represent some improvement because the deaths have been improving. But the problem is that these statistics and the way they're collected has been changing almost with each report, which makes them a little bit flawed. So I'm not going to be quoting you the percentages of deaths in too much detail, simply because each report has been done slightly differently. But probably 2 to 7% of deaths are anesthetic related, depending on the report that you read. The last one, 2% of deaths were anesthetics. And anesthetic deaths are almost always classified as avoidable, and that's what makes them such an attractive target. There's always something we could have done better, and about 90% of them are avoidable deaths. And finally, these reports underestimate the contribution of anesthetic and anesthetic mishaps to maternal mortality, and I'm going to come to that just now. But really, if you look at only the direct anesthetic deaths, you're underestimating all of the other contributions anesthetics makes to perioperative safety. So if a patient with postpartum hemorrhage is poorly resuscitated intraoperatively, that is an anesthetic issue, but it will be classified as an obstetric death. So even though there was an anesthetic contribution, the death won't be ascribed to anesthesia. And that means that our negative contribution is underestimated. This is from the most recent report, and it's a table looking at the primary obstetric causes of maternal deaths for the triennium 2020 to 2022. And there are two aspects really that I wanted to highlight in this table. The first is that non-pregnancy related infections formed a much higher proportion of deaths than it usually does, 29%. And that's because of the COVID pandemic, and it skewed a lot of the results. So all the percentages are thrown off a little bit by these COVID deaths. The second thing that I wanted to highlight was anesthetic complications, averaged out at 2.1% of deaths due to anesthetic complications. But if you have a look at 2022, 4% were due to anesthesia, which is quite a high number, 39 deaths. And it's in that period where the COVID deaths were starting to fall away. So anesthetics remains an area that needs to be targeted. Another worrying signal is where these deaths are happening. Now, if you look at the total deaths, maternal deaths across the different levels of the health system, you'll see that the deaths increase as you move to a more complex or well-resourced health system. So the community health centers, 3%, the district hospitals, 21%, the regional hospitals, 31%, and then the tertiary hospitals, 36%. And that's appropriate because the sicker, more complex patients are referred up the chain of the healthcare system, and those patients have a higher likelihood of dying due to the nature of their disease. So that's how it should be. If you look at anesthesia, however, it goes the other way. And anesthetic complications and deaths from anesthesia occur at the highest rate in district hospitals, followed by regional hospitals, followed by tertiary hospitals. And that's probably because we've got specialist anaesthetists, and even though those deaths are occurring in those hospitals, they're not due to anesthesia because we've got well-trained, highly qualified anaesthetists. And you don't tend to find those type of doctors in district hospitals just by the virtue of the way the health system is set up. So the avoidable anesthetic deaths that occur are happening at district level, and that's something we need to address. Another point worth noting is that when you look at the overall causes, the number ones for institutional maternal mortality rate are still hypertensive disease and obstetric hemorrhage. Again, there's that spike of non-pregnancy related infections, which are 35%, but that's unusual and shouldn't recur. So those ones that we're used to, hypertension, hemorrhage, are there. There's miscarriage, ectopic pregnancies, anesthetic complications is in there. So the same problems that we've been dealing with for over 20 years are still there, even though we are getting better at them. And that's got important implications for anesthesia. Now, the report for the triennium 2017 to 2019 had, it's the only report to produce another kind of statistic related to anesthetic morbidity and mortality. Now, in this report, we classified the anesthetic deaths as one of 4 categories. The one was death due solely to the anesthetic, but we also classified deaths as death due to another cause like hemorrhage, but where action or inaction by the anaesthetist might have contributed significantly to the death or the events leading to the death. The other categories were substandard anesthetic, but that didn't contribute to the death, or no substandard anesthesia care. And very interestingly, 7% of perioperative deaths, remember that's excluding the other deaths that didn't have an operation, that's why it's so high, but 7% were the direct result of anesthesia, and a further 15% had secondary anesthetic problems, implying that anesthesia contributed to the outcome but wasn't the primary cause, such as a bad resuscitation or an inadequate resuscitation in postpartum hemorrhage. And what that tells you is that 1 in 5 patients, 22%, of the patients that die that have had a cesarean section, of the perioperative deaths, anesthetics plays a significant role in contributing to that negative outcome. And that's probably true of all the reports that we've had. We've just never collected the data. What they highlighted that were avoidable anesthetic factors: poor or inadequate resuscitation, delay in diagnosing complications, so there's a high spinal or spinal hypotension or bleeding and it's picked up late. Failures in postoperative care, usually occurring in recovery, where we've signed patients out that are tachycardic or hypotensive or still bleeding, and they're signed out to the ward, and then the negative event occurs in the ward. And choosing the inappropriate method of anesthesia, and usually this is us choosing a spinal anesthetic when we should have been doing a general anesthetic. Other signals that this report highlighted, which I think are still true and which are going to result in a few talks on the subject in the next couple of months. The first is that there's a trend to performing evacuations of the uterus under sedation with no patient monitoring and a single operator administering the sedation and performing the evacuation. Now, that may be acceptable when you've got a straightforward healthy patient, but in a sick patient, it's unacceptable. And the rules for sedation in these patients depend on the sedation that you're employing and the level of illness of the patient. And so we're going to be doing a talk on sedation in a month's time to address this issue. The second problem is that hypotension after the administration of anesthetics is a major morbidity in 25% of mothers before delivery of the baby and in 35% of women after delivery. So it continues to be a major problem, and you'll find talks on the channel about how to address that hypotension, remembering that we need to counteract the vasodilation of the spinal, and remember that there may be other causes of hypotension, such as bleeding or cardiac issues. And then finally, it's an alarming observation that in 2.5% of cases where there were deaths, the anaesthetist also performed or assisted with the surgery. Getting on to some more specific causes. Ectopic pregnancies have been highlighted in numerous confidential inquiry reports. 1/3 of deaths of ectopic pregnancies occur in district hospitals. 86% of the deaths in district hospitals are classified as avoidable. And some of the major things that are highlighted are that there's a delay in access to healthcare. Either the doctors are too busy or they don't have the skills, the ones that are there. And very importantly, delays in diagnosing either the primary problem, which is an ectopic pregnancy, or in diagnosing the severity of the illness, which means that the resuscitation that follows is inadequate and doesn't occur quickly enough. And in 38% of patients who died from an ectopic pregnancy, no anesthetic was given, which means no surgical intervention was carried out. Now, this is obviously a very negative finding, because the only treatment for a ruptured ectopic pregnancy is surgery. And if we're not even getting to anesthetics, we failed the patients. And if you speak to the doctors in these settings, it's often the fear of the anesthetic, not the surgery, which seems to prevent these patients getting to theatre. So in terms of this problem, we need to do better, and that means resuscitating well, diagnosing well, and importantly, operating on site. We can't be putting these patients in ambulances because they die en route to the hospital. So they need to be resuscitated, and part of that resuscitation is taking them to theatre. In order to do this, we need to prepare ahead of time. So it means we need to practice general anesthesia on other patients that are well. So we're not unfamiliar with a general anesthetic when it comes our way. And probably these are the sorts of things you can run drills in your hospital. How do we cope with a hypotensive ruptured ectopic pregnancy when the patient comes in? And you can stick to very simple recipes, which I'm going to show you in a second. It is possible to do these patients in very basic manners. And the key is the focus on the resuscitation from the fluid aspects. And remember that you can ask for help. That means on-site hands, get everyone who's available into the theatre, and off-site advice, phoning your regional or tertiary hospital, whoever you refer to, just to get advice on how to cope with these sorts of patients. Now, if you're interested in getting better at anesthetics for ruptured ectopic pregnancy, we've written this article which attempts to break down the problem as simply as we can. We stress that you have to take these patients to theatre. Medico-legally, I believe it's far more defensible to have tried and failed than to have not tried, because everybody knows that the only way to get them through is to take them to theatre. We try to simplify anesthesia into this wall chart, where basically there's little checklists on the side that'll remind you of the order of things and what you should put on patients. And then we break it down into induction, maintenance, and emergence. And the induction, you just choose one induction agent, one paralysis. There's your ventilator settings, how to maintain, and then how to know if you can extubate the patient at the end. Remember that if this doesn't work for you, if this is even too complicated, you can do a ruptured ectopic pregnancy purely with ketamine. It's not advisable. If you do have to do it this way, then the next time you need to have hopefully improved your skill set to do it in the proper way. But even doing it just under ketamine is a better option than not even attempting it. And that's the sort of anesthetic that I would give with your cell phone in your hand. You phone somebody who knows what they're doing, and you ask them about how to do these patients. And really, you can just give ketamine and put an oxygen mask on the patient if that's all you're able to do. But as part of any resuscitation, often this requires intubation, and so often that skill set is available in the hospital. And you can just reduce the anesthesia to ketamine when the patient moves. And as part of the recommendations that have come out of the recognition that there's a lack of skills in district hospitals, in some district hospitals, to do general anesthetics, is the ESMOE training program. And so these reports, the most recent one has recommended the ESMOE board to be reconstituted and modules updated and the program to restart. It's stopped for a few years because of basically funding deficiencies. So ESMOE training, including anesthetic ESMOEs, is going to be compulsory for all new staff. There should be 2 yearly updates for existing staff. We are aiming to get drills and exercises going that should occur monthly in maternal facilities, and this is very important at primary care and district hospital level. And each hospital the goal is to have at least one on-site trainer that can run these relevant ESMOE modules and drills. The new the new intern handbook in the anesthetic component requires that ESMOE training has been done for all interns. This is a national requirement. And if you want to know about the theory or the content, if you go to the YouTube channel that this talk is on, and you look at playlists, you'll see an ESMOE playlist with all the talks on that are required for the theoretical component. And if you click on that, you'll see there's 7 talks dealing with the most common issues in anesthesia given by experts from all over the country. All the universities are represented. So you can watch the theoretical component. And then as part of the goal for next year, we are busy compiling the notes that will go with these talks, which will hopefully be available through a central platform like Knowledge Hub or whatever we can find. And then we're also putting together drills that will be available on that platform as well, so that everybody will have access to at least the teaching material. And these are the sorts of courses we've got to run to get the anesthetic skill set better. And then once you've maybe done your ESMO-E course, you can think of more complex courses like the Safe Obs course. This is just a reminder that while district hospitals, if you look at the deaths that are occurring in district hospitals, 24 under spinal and 5 under general anesthetic. You compare that to the tertiary hospitals where 7 were under spinal and 2 under general anesthetic. So the numbers are much bigger at the district hospitals. But it's quite worrying that 24 occurred under spinal anesthetic, which is the opposite of the pattern that occurs in other countries. And the question really is, are we doing spinals because we made the wrong choice of anesthetics, or is it the only choice that we have, meaning that we haven't done enough general anesthetics to feel comfortable doing a GA when it's indicated? If you look at the reports from 1999 to 2013, you can see the deaths in each triennium by the type of anesthesia administered, and the blue portion at the bottom are the deaths that occurred under spinal, and that trend is just going up and up and up. And this was the period where spinal anesthesia came to the fore as a safer anesthetic than general anesthesia. So we started doing spinals for everyone, and as a result we lost our general anesthesia skills, and this has had a negative impact in terms of what skill sets are present in every hospital. And this is something that we need to address. We need to find ways to do general anesthesia, hopefully on patients that are not as high risk. So maybe our postpartum tubal ligations or burns patients, the small burns that we do at district hospitals, or the evacuations of uterus. We need to find ways to do safe general anesthesias with adequate supervision, so that when we do the ruptured ectopic, or when we have the tachycardic patient for cesarean section, we don't put the wrong anesthetic in and do a spinal, because that's all we know. Finally, one of the messages that the confidential inquiry has been putting out is that we get our antibiotic prophylaxis right. There is a fair amount of puerperal sepsis and patients coming back with either wound infection or necrotic uteruses and that have poor outcomes. So this is just a reminder of what the current national guidelines are. The protocol recommends that you give cefazolin, and remember that it's weight-based. If they're under 60 kilograms, they get 1 gram, 60 to 100 kilograms, 2 grams, and over 100 kilograms, 3 grams. This is what the EML, the Essential Medicines List, recommends. And you should give that half an hour to an hour before skin incision. Generally, this is done in theatre, so the first thing that happens when the patient comes into theatre is that they get the antibiotic, then you start thinking. And usually that'll give you at least half an hour before the baby's out. But the important thing to note is that it's not only cefazolin, you have to give 2 agents for all cesarean sections. So the other agent that's in the recommendations is azithromycin, 500 milligrams intravenously. This is supposed to be given an hour in advance. The problem with azithromycin is you have to give it over an hour with a 60 dropper. And giving it slowly over an hour, it's been shown to work, but it's difficult to regulate that flow. And if you give it too quickly, you find very hypotensive patients. So in recognition of that, KwaZulu-Natal has said that it is also acceptable to give metronidazole 500 milligrams IV instead of azithromycin. So currently in KwaZulu-Natal, we are giving cefazolin at the weight-based dose plus metronidazole 500 milligrams, but the national guidelines, which are in the EML, recommend cefazolin and azithromycin, and that is the same in the recently released maternal care guidelines of 2024. It's just that the maternal care guidelines have neglected to put the weight-based dosing of cefazolin, which is recommended in the EML. So get your cefazolin dosing right, and then choose either azithromycin or metronidazole based on what you think you can deliver safely and consistently at your institution. And this makes a big difference to sepsis around Caesars, halves the incidence, something like 12% to 6%, depending on the study that you read. And that's all. I hope that's been useful. These reports come out every 3 years, and they're worth reading for the signals that they give you. Thank you.